Good afternoon, everyone. And we're so grateful and delighted that you are able to be with all of us tonight. So let us pray. God, we certainly thank you for allowing this event to take place tonight. We give you thanks for all that are here. Lord, we ask that your spirit would be with us. Give us your wisdom, your understanding, your counsel, and your might. God, let this be the beginning of unity and love and peace in this nation, God. We're so grateful and thankful that you have chosen Tuskegee, Macon County, Alabama, to host this event tonight. God, may the spirit of Tuskegee be with each one of us as we leave this place. But now, God, we just invoke the presence of the Holy Spirit here. Lead us, guide us, and direct us. Be with the speakers, Lord God, and every person who is a part of this event. And this is the blessings that we ask in the name of your Son, Jesus. Amen. At this time, Mayor Haygood will come with the welcome. Thank you so much.
Thank you, Reverend Love. Good evening. On behalf of our City Council, the City of Tuskegee, I want to welcome you to the City of Tuskegee. I think we have one council person here, it's Ms. Norma Jackson. So we will invite all of you to return to Tuskegee. We're particularly pleased to have you here with us this evening for this important program. Welcome to all our esteemed panelists and guests here, Dr. Watson, Dr. Sodeke, who will be leading some of the effort here. We thank you for your work with the entire team, and we look forward to what you have to offer to us. We're excited because Tuskegee hasn't always been the right place, hadn't been known as the right place to do research. Well, when you're doing good research that shows the differences we have and how, in recognizing those differences, we can treat them in the right way. As we are individuals, let's get the right treatment for those individuals, for our families, and for our differences. Whatever our race, our ethnicity, our location, the environments that we've been in, we're exposed to different things. So we want to be able to do that the correct way. And that's what all of us seems to be about. I'm excited about all of us and what it can do to improve the health for all of us. And let's recognize that. Regardless of what's happened in the past, let's have an open mind to understand that there are people who care about us, who want to do things the right way, so that we in the future can be healthier and better, and our families will have better results. If we know what we're dealing with, then you can treat it the right way. And that starts with the proper research. So we're particularly excited to have each one of you here today to enlighten us, to share with us, and to help us get ready to be better and healthier so that our families are healthier and the next generation is even better. Again, on behalf of the entire city of Tuskegee, and in particular our city council, I welcome each one of you. I want to thank Reverend K.G. Jones and Bethel Missionary Baptist Church for opening its doors, as they always do in the community, not only inviting us here, but making sure we're getting good information and taking care of our community. Welcome to Tuskegee and Macon County. It's always a great day in Tuskegee when we have folks like this.
Good evening. My name is Dr. Stephen Olufemi Sodeke. I serve as resident bioethicist within the Center for Biomedical Research. I'm also the site principal investigator for the All of Us research program. And to use the football analogy, I have the privilege of being the quarterback at Tuskegee for the All of Us research program. It is with gratitude to God and humility that I stand before you today in this sacred place and on this hallowed ground to declare to you from the Word of God that we are all God's workmanship, masterpieces, created in Christ Jesus to do good works, which God Himself has prepared for us to do before time. I want to acknowledge my wife, who is somewhere in the audience, whether online, for her consistent support in many ways, but particularly with prayer and fasting. I also want to thank my other prayer partners who are in the audience, locally, nationally, and internationally as well. It is with deep appreciation that I recognize the foot soldiers from our communities in Tuskegee, Birmingham, and other cities in our catchment areas who served passionately on the planning committee with PISIC's partners and NIH representatives to help bring to life this two-day program. I request the audience to hold their applause until I finish calling the names of the foot soldiers, and we will all applaud them together. From Tuskegee, Miss Cheryl Ferguson, where are you? Stand up. Are you here? Way back there. Miss Cynthia Wilson, perhaps very close by. Councilwoman Norma Yabody Jackson, where are you? Okay, somewhere down there. Miss Patricia Goulet and Dr. Lucinia Dunn. From Birmingham, Ms. Sharon Hardy, Mrs. Edrica Miskel, and Dr. Shantiz Allen. The planning committee did an outstanding job coordinating and transforming this place into a place where this can be viewed not just here in Tuskegee, but in the nation and all over the world. With gratitude, let us give them a round of applause. I want to thank everyone in this audience, particularly those in the Amen corner. You know yourselves, for coming to bless us with your presence today. May God bless our time together. Somebody say amen. Amen. So let me now take a moment to set the context of our time together this evening. Well, you know the news already because you are here. What we don't know is the rest of the story, because we are writing the story even as we speak and as we convene here today. So for the purpose of this occasion, I will title this story, You Never Know Unless You Go. Moving forward from promises to progress. This story will not be complete without you who are in the audience. We will depend on you to help us tell your part of the story from this day, and perhaps for many years and generations to come. May I take a minute to share with you my part of the rest of the story? May I do that? All right. Fasten your seatbelts now and get ready to take off. It is an honor to host this event in partnership with my brother, Dr. Karriem Watson. Dr. Watson and I wish to say to you, in the words of Joseph, Jacob's son, who said to his brother when they met him in Egypt and could hardly recognize him, Joseph said to his brothers, "Come closer. We are your brothers. It is for such a time as this that God sent us ahead of you." My part of the story begins like this. Today is a special day. It is a day of celebration because God made a way. We serve a God that seems to make a way where there is no way. I'm full of joy today because we are in the process of making the invisible visible. We're here to say we count, so we will dare to be counted among those who would change the future of health for all of us through breakthroughs in scientific research. We have the power to drive health research now for all of us and for generations to come because we are in this together. Are you full of joy today? It is the day that the Lord has made. Let all of us rejoice and be glad in it. So how did we get here? On May 6, 2018, I joined by invitation the likes of Dr. Selwyn Vickers, Dean, UAB School of Medicine, Dr. Francis Collins, then Director of NIH, and Dr. Dara Richardson Heron, then Chief Engagement Officer, to launch the All of Us Research Program. As I was speaking from Birmingham, Dr. Francis and others were speaking from different locations across the nation, like Nashville, Tennessee, New York, Chicago, California. My 6-minute speech featured not obstacles or difficulties that we may encounter, but was centered on the promise that this NIH research program offered and the role of the community in consultation and in taking advantage of the opportunities and initiatives that we must not just pass up if we are serious about ensuring health equity, not just for some of us, but for everyone. I reasoned that in order to take advantage of opportunity, someone had to step up to the plate because, I say again, you never know until you go. So thanks to Dr. Bruce Koff, Dr. Mona Fuad, and Dr. Beth Lewis, the principal investigators for the Southern All of Us Network at the University of Alabama, Birmingham. Where are we going today? Today we are here to continue the writing of this story. For these community-centered, principled engagement and consultation sessions, yes, we will address the elephant in the room, the difficulties, the challenges, the fears, the necessary and continuing healing needed resources or lack thereof. But we will do more than that because we want to be part of the solution. We have faith and we have hope. We expect boundary-pushing, two-way conversations that, I might add, may be visibly passionate at times. So today is also a day of a call to action. We must get it right, and we must move from promise to progress together. The important contribution we need from this community today, this gathering right here and now, is to help us tell part of the story of our looking back in order to move forward. That story will not be complete without the contribution that you make tonight. Help us understand and address the burdens, concerns, and fears about research we need a community-informed plan or plans to discern the next course of action in our efforts to ensure precision health and precision medicine that will improve all of our health. To conclude, our purpose tonight is threefold. Number one, we're going to work to acknowledge and address the historical concerns and fears about research because of where we have been. Number two, we're going to discuss possibilities, opportunities, actionable and sustainable steps that will lead us to where we are going. So looking inwards and looking outwards, what has to change? Who will and should do what moving forward? I want to express my sincere appreciation to our panelists, Mrs. Lillie Head, Ms. Veronica Robinson, and my friend and brother, Dr. Karriem Watson, for answering our call to work together at such a time as this. Dr. Joan Harrell is our moderator for the day. Dr. Harrell is, I'm just going to invite you to introduce yourself and hand over the talking stick to you. Thank you, Dr. Harrell.
Thank you, Dr. Sodeke. And with that said, within the context of community, to say it is an honor, an humbling honor to be invited to moderate this panel at such a time as this in our history for, within the context of our people, if you will. We are literally standing on the shoulders tonight of enslaved Africans who walked these hallowed grounds. This is also the location where in the mid-19th century that Dr. Booker T. Washington established Negro Health Week. And it is now recognized nationally as Minority Health Month in the month of April. So it is not by chance that yet our ancestors are still calling us to be responsible for health care. And within the context of introducing myself, how is it that I'm sitting here and staying in line with Dr. Sodeke's spiritual references? It was only God, I will say, that brought me to this space 10 years ago in 2013, when I was invited to travel back and forth between Chicago and Washington, D.C., where I had the opportunity to meet Lillie Tyson Head, her family, and other descendants of the syphilis study, to begin working with them to help them, if you will, and I always felt uncomfortable saying help them, but to guide them, to be a counsel in leading them to share their story from their perspective as being descendants of the 623 men who were unethically treated and immorally treated in the United States Public Health Service syphilis study. And with that said, I'd just like to begin by saying, please let us be intentional about the word all of us. Because tonight we have the opportunity to continue the work of Dr. Booker T. Washington and other unnamed enslaved Africans. We have the opportunity to be more responsible as a community, not only to name the history, but within the context of calling to action and ensuring that the treatment of our people, that we will move forward and speak the truth tonight. And with that said, we will go and carry on this conversation in this order. To my right, Lillie Tyson Head, who is the president of the Voices for Our Fathers Legacy Foundation, which she and other members of the Descendants of the United States Public Health Service Syphilis Study started in 2024. Following Ms. Head, as each panelist will speak for 10 minutes, and then we will engage in an open conversation. Afterwards, we will invite the rest of the community to participate, to let us know what it is that you want to happen after tonight. It is time for us to stop talking and commit and dedicate ourselves to action. Following Lillie Tyson Head, we will hear from Veronica Robinson, who is the descendant, the niece,
Henrietta Lacks.
yeah, of Henrietta Lacks, who is, as you know, Henrietta Lacks is the woman we know, unfortunately. We just really begun to know her full name, but she was known as the HeLa cell. And so Ms. Robinson is here to talk to us about the critical nature of her being an advocate for patients' rights. And last but not least is Dr. Karriem Watson, who is the Chief Engagement Officer for the All of Us program with the National Institutes of Health. And no, I have not forgotten Dr. Sodeke. He will, as he's introduced himself, he is the resident bioethicist for Tuskegee University, as well as the private investigator and board member for the All of Us program. Ms. Head, why don't you begin?
Thank you, Dr. Harrell. And I'd like to say that you mentioned that you always felt a little uncomfortable saying helped. I would like to say you joined us in spreading our word. So thank you for doing that. It's been a pleasure to have you on board. I'd like to acknowledge Dr. Sodeke, Dr. Harrell, Mrs. Robinson, and Dr. Karriem Watson for being here this afternoon. It is humbling, it's a privilege, but it's also a wonderful opportunity to share our story. It is indeed a pleasure to be with you this evening on behalf of Voices for Our Fathers Legacy Foundation. This foundation was formed in 2014 by some of the descendants of the 623 African-American men who were unwittingly subjects in the United States Public Health Service study of untreated syphilis in the Negro male in Macon County and Tuskegee for 40 years. I would like to thank Dr. Karriem Watson, for inviting me to share our story and how our stories, hopefully, will give rise to deeper thoughts on how the history of research and clinical trials have impacted African American communities for generations. I commend everyone who helped to favor Tuskegee by bringing this important conversation and research program to Tuskegee and Macon County. I am Lillie Tyson Head, a retired health and physical education teacher for 31 years in the Waterbury school system. I'm also a former education consultant, proud graduate of Tuskegee Institute, now Tuskegee University, Southern Connecticut State University, and the University of Bridgeport. I'm married to my soulmate, for 53 years, but come March 1st, it would be 54 years. I am the mother of 3 adult children and their spouses, and the grandmother of 3 darling grandchildren. I was blessed to be born the 7th child to Freddie Lee and Johnny Mae Neal Tyson. It is my parents' legacies and experiences that I have shared with Macon County and Tuskegee that have shaped my moral compass and perspectives on the work that I am engaged in with Voices for Our Fathers Legacy Foundation. And this is what brings me here tonight. Allow me a little time to tell you just about a little about my father and the infamous study that he was deceitfully subject to, along with several of his neighbors, church members, and cousins. You might have heard or know of the study by its name, Tuskegee Syphilis Study or the Tuskegee Experiment. Both names were misleading and misguiding from the beginning. By placing Tuskegee first, it gives ownership of the study to Tuskegee and not the United States Public Health Service. These names place ownership, accountability, and responsibility all at the front door of Tuskegee. With much passion, the foundation is transforming the legacy of this study from shame and trauma to honor and triumph, starting with correcting the name. The name of this egregious study is now referred to as the United States Public Health Service Study of Untreated Syphilis in the Negro Male at Tuskegee and Macon County, Alabama, from 1934 to 1972. Notice that the word untreated you have not heard much, but when you add that to the name of the study, what you are telling is your intent or the intent of that study from the very beginning. So why was it so conveniently omitted? Help us now to make sure we call the study what it was and what it was intended to be. This study lasted for 4 decades with the sole purpose of using 623 beloved men as lab guinea pigs. To this day, as a descendant, I have not seen any conclusive data in regard to the biospecimens and the research. What was learned from collecting and testing 40 years of blood sera and the biospecimens? How were these samples used and where are they today? Were they shared in other research? Knowing that this study's main purpose was to test the damage that syphilis caused on their cardiovascular system and prove that little damage would be done on their neurological system. Why? Because Black men were considered less than and different from white men. Some scientists pushed the idea that Black people were intellectually inferior because of their genetics, which allowed misunderstanding and cruel treatment. This ideology was the widely accepted and practiced eugenic theory. The study continued following the deterioration on the human body caused by syphilis within these men's bodies. The focus and interest were placed on the men's death and their biospecimens. My great uncle was one of the men whose specimens were used. For 4 decades, many of these men were denied the penicillin treatment after it became available in the mid-1940s. Some of the men, their wives, and their infant children died due to non-treatment. Like my father, the doctors never informed them that they were in a study, that they were not being treated for their bad blood that they had called it was, and that they had syphilis. They did not give consent to be a part of a study for non-treatment. They trusted what the doctors had promised, treatment. Imagine trusting in a time where you were considered less than and lived in a place where you were always downtrodden and treated subhuman. Last year, Millbank Memorial Fund President Christopher Collier and some of its board members came to Tuskegee University to apologize for their financial support of the study by providing funds for burial insurance for the men's families if they agreed to a biopsy upon their death. This was also used as a promise and an incentive to keep the men in the study. This was not only an example by the Millbank Memorial Fund, the acknowledgement of past wrongs that caused immeasurable injustices, but it illustrates that reparation and reconciliation can lead to acceptance and partnerships that can bring about healing, positive changes, and good from evil. American Society of Human Genetics joins other societies and organizations that have recently acknowledged and apologized for their roles in promoting social injustices and racism. My father died as a result of a car accident, driving to work early one spring morning at the age of 82. During his entire lifetime, he stayed healthy, remained in good physical shape, kept a positive attitude, and kept his faith. With little formal education, Dad was self-taught and very wise. He was a carpenter who helped build Moulton Field, St. Joseph's Elementary School, and several other buildings in Tuskegee. He loved to garden, fish, barbecue, tack quilt during those cold winter months in Connecticut. My father, like most of the men in this study, were sons, grandsons, fathers, grandfathers, great-grandfathers, brothers, husbands, uncles, neighbors, pastors, and deacons in their church and pillars in their small communities. They were loved and they loved. They were all human beings, but their humanity was ignored. It is still painful for me today when I think of the needless suffering, deceit, silence, shame, and deaths caused by the Public Health Service study of untreated syphilis. And hesitancy and mistrust continues to plague us in critical health decisions. I do not consider my work as my work. It is not my work. It is our work. After learning that my father was in the longest lasting non-therapeutic study in U.S. medical history, I asked my father how he felt about the study and being a part of it. He calmly but sternly said, "I can't do anything about what happened to me and all of those other men, but it's up to you to see that something like this never happens again." History has taught us thousands of lessons about how social and racial injustices have dehumanized Black and brown people. The question for us is, what do we do with what we know in pursuit of securing our future? In closing, I ask that we, all of us, remember my father's words. It's up to you all. And this will take all of us with God's divine grace. It will allow us to continue to move forward together, bringing something good from evil. Thank you for your time and listening.
Thank you, Mrs. Head. Ms. Robinson, and then Dr. Sodeke, you will follow Ms. Robinson.
Okay. Today I had so many things that I wanted to talk to everybody about because I believe that everything that come out your mouth, you should make it count. Because somebody's going to take that back and hopefully we use it to build our community. But just like God, just in a God fashion, he definitely took everything that I wanted to say and changed it up. So today, I'll share a brief about my great-grandmother. Her story was she received care in a time where there was only one institution in our community that would give her care. It was now one of the larger institutions, Johns Hopkins. When she went to Hopkins, she believed that they had her best interests, as most of us believe when we go to these institutions. We try to be trusting because we have families that we need to get back to. My great-grandmother was responsible for the HeLa cells. And she received, the care she received, they sold these vials to her cervix that were burning her from the inside out. So she was dying a very long, painful death. She wanted more kids, and she was never told that the treatment that she was receiving would not allow her to be a mother again. She had to watch my grandfather and aunts and uncles from a hospital window, as many people had to do when your family had started to get COVID. When we have these conversations in our family, it's always said when it comes to health, science, and research, it's like our family was always on the front line of all the bad things that could possibly happen. From the care she received, taking her cells without the family permission at the time of her death, going and giving a speech talking about these miraculous HeLa cells with no thoughts of the family who was grieving on the inside, refusing to say her name, calling her Helen Lane or Henry Lawson, anything, because they didn't want to accredit her cells to a woman of color, because they were scared that research couldn't move forward if they knew that it came from a woman of color. To the cells cross-contaminating labs all over, because doctors would take these small vials, put them in their pocket, and the cells would just take over everything. They said if you put her cells in a petri dish, it would take over the other cells in the dish. My Uncle Sonny, who's now passed away, he always would say, when he heard these things and he got to see how powerful her cells were, he said, my mom was a bad woman in life and she was a better woman in death. All these things she did. Bear with me, guys. My great-grandfather used to say I'm mouthy, and hopefully it proved to be a good thing today. So then, once the cells contaminated the labs, they came back and they said to our family, they said, my Aunt Deborah being the only Lacks woman that's directly a descendant of her mother, they said, hey, we would like to get a sample of your blood because we would like to see if you're going to die from what your mom died from. How traumatic. When my great-grandmother when she lost her life, my family, they went through so much having others care for them. And then you have this institution come and say, we just want to see if you're going to die from what your mom died from. My aunt asked questions, no real explanation. They gave her a book. She was young. The words in the book, she wouldn't even understand. It would take her forever to use a dictionary or thesaurus to really break down it. And still, in medical terms, she still wouldn't get certain things. So after that happened, they took samples of the blood, and they never said that she wasn't going to die, she was going to die, but it was to be sure that there was no more contamination in the labs. And once they found out that the cells were contributed, that came from my great-grandmother, they never even told the family. It was in the 70s where the family found out by accident. My grandmother, Barbette Lacks, having dinner with a friend whose brother was in research, said, hey, Lacks is not a common name. Would you happen to know a Henrietta Lacks? My grandmother said, well, only Henrietta I know is my mother-in-law, and she's been dead for so long. He said, yeah, that's her. We have her cells in the lab. And my grandmother, she still couldn't grasp the concept of what all this meant, but she jumped up from the dinner table and she ran a few doors down to tell my grandfather what she had learned. Then articles came out like the Rolling Stones, and still no one had given the family an explanation. Our HeLa genome was released without the family permission, which led to a larger conversation in our family, bringing Dr. Francis Collins and Kathy Hudson to give us a crash course on what our genomic data and makeup meant for us, and giving us the opportunity, even though they say that the cells are public domain, meaning that the cells don't belong to the family, they now belong to anyone who wants to use it. But how could that be when we never even knew that her cells were being used? We were robbed before we even knew. So we decided as a family that we wouldn't allow ourselves to be victims, but victors in telling our own story. It's an African proverb that says, and I don't want to tear it up, but it says, until the story of the hunted is told, until the story of the hunt is told, the story of the hunter will be glorified. So our family have all came together under one hub of HeLa 100, and we became advocates unknowingly to the mother of modern medicine, Henrietta Lacks, by being the trusted voices in the community, by amplifying her voice in stories that are quite like hers and your story, and other people who have been silenced. Today, most of my focus will be on being very deliberate and transparent, because these are the things, as he said, moving from promises to progress. Obama said, we are the change that we seek and we are the change that we need. So I'm just keep looking at Karriem. He's like been like a mentor, a big brother, and he brought me here today. I'm always nervous, and he always like cool it down. But it's been an honor to be able to be on this platform with such great people to share a story that has touched a lot of you in the same room.
Gentlemen, if you don't mind me saying, I'd like to personally thank you, Ms. Robinson, the great-granddaughter of Henrietta Lacks, and you, Ms. Lillie Tyson Head, the daughter of Freddie Lee Tyson, for sharing your sacred stories. Thank you. Dr. Sodeke.
Thank you so much, Ms. Lillie Head, Mrs. Lillie Head, and Ms. Robinson, for helping us to remember by sharing with us your rendition of the personal and lived experiences that you've had ever since. You know, it was public outreach that halted the syphilis study in 1972. Immediately that happened, the government knew that they had to find ways to do business differently so far as medical research was concerned. So there were then a series of congressional hearings, which then led to the enactment of the National Research Act in 1974. That act enabled the establishment of the National Commission for the Protection of Human Subjects of Research. And that commission then met at the Smithsonian Institution, Belmont Conference Center, to have a very vigorous, intensive 4-day debate, because they have been charged with coming up with basic ethical principles to guide human research. They have been charged to figure out ways in which we can do things better. And so, in 1979 then came what we now refer to as the Belmont Report. You may recall that I did say that they met for an intensive discussion, the commission that is, 4-day intensive discussion at the Belmont Conference Center of the Smithsonian Institution. That's where the name of the historical document came from, the Belmont Report. Of course, that 4-day discussion was not what produced the Belmont Report. that would be very, very far from the truth. And if you guess that it took a fairly long time to actually put such a noted historical document together on which many of the ethical guidelines that we use these days came from, you'll be right. Because it would take another 4 years of back and forth discussion before that report was written and produced and published in the Federal Register in 1978. And finally, it became easily accessible to anyone that wishes to do it in 1979. That basic document had 3 ethical principles, basic ethical principles. And if you would guess that the first thing would be to respect people for who they are because of their humanity, you'll be right. The very first ethical principle is respect for persons. Respect for persons. The men in the syphilis study were not given that opportunity. They were not told clearly what was going on. You heard Ms. Lillie Head talk about that. But the ethical principle would be utterly useless unless it's translated into a way in which it could be implemented and applied. And so the practical way to realize the principle of respect for person is what you and I have now come to know as the informed consent process. That means before you do anything to anyone, you have to explain what it is that you are about. Inform. Give the person or persons the opportunity to think about what it is that you wish to do. And then, because they are autonomous agents, capable of mapping out their own life and taking responsibility for it, you have to give them that opportunity to say yea or nay. Yes, I want to do it. No, I don't want to do it. And it's not only informed consent that is absolutely necessary so far as medical research is concerned. The next or second principle, basic principle, is beneficence, right? Beneficence, doing good and avoiding evil. In other words, doing things that are beneficial and avoiding or minimizing any harm that you can think about. So this is translated to the fact that every research that anybody, whether it's biomedical or behavioral or social, you need to weigh the benefits against the risks of that particular research. That's where that comes from. The third principle, basic principle, is the principle of justice, fairness. Fairness in terms of making certain that the participants or subjects of medical research are selected in a fair way. You are given the opportunity, if you will, to participate by making aware all of the benefits that may accrue from such a research are distributed also fairly. So the burden and the benefits of it are equally equitably, fairly, if you will, distributed. So that we don't want a situation where only one race would be in a clinical trial, for instance, right? In other words, we will develop drugs that will work for who? For people who were there, who had their data there. That is why it's so important for us to, if we're serious about our health and health equity, to step up. Yes, it's burdensome. Yes, it's risky. And we must carefully raise the right questions. This Belmont report is pivotal to all of the medical research rules and regulations now that now guide all the 14 of the institutes under NIH. We call that document because it's translated now to rules and regulations, which provides guidance, which the Institutional Review Board and Community Advisory Board can then use to judge, if you will, any research at all that's placed before them. We call it 45 Code of, Chapter 45, Code of Federal Regulation, Part 46. So these guidelines are already what guides current day research and researchers so that we can be sure that they are aware they are ethically obligated to fulfill all of these regulations and guidance and be certain to do research that ethically, not only ethically permissible, but ethically obligated and ethically right to do. So doing things the right way is the basis for all of these philosophical argument that I have been placing before you. This is where we are today. Guidance are there, rules and regulations are there, institutional review board are there. These are third parties that try to review all of the research that involve humans under the guidance of these regulations that I just talked about. Let me just stop there, and perhaps we can have other conversations during the Q&A. I yield the rest of my time to the moderator, Dr. Harrell.
All right, thank you, Dr. Sodeke. With that said, Dr. Watson, please share with us, within the context, you are the public engagement officer for all of us. Can you share more with us about what does that look like, especially for, you're sitting next to the descendants of the women and a representative of the men who gave their lives for us to be at this point tonight.
Thank you so much for that. And tonight is really a humbling moment. And when you think about, we're in the month of February, Black History Month, and we're in Macon County, Tuskegee, Alabama. And as the Chief Engagement Officer for the All of Us Research Program, someone said, well, Karriem, why this conversation now? Why this conversation in this place? And it's because of everything that we've heard tonight that we have to have the conversation now. We have to have the conversation in this place, and we have to have the conversation with these people on this panel. It's the right time, it's the right place, and it's the right people to have this conversation, to move us from promise to progress. And when I have to go back further than just about the All of Us Research Program, because I'm sure people keep hearing this name, the All of Us Research Program. What is it, and what does it mean? But for me, it starts long before the All of Us Research Program. And what brings us all here today is our lived experience and our family experiences. And I have to go back to my family's from the South. And my mother was from Mississippi, my dad's from Arkansas. And when growing up in Michigan, as a young child, my mother was diagnosed with breast cancer. you don't know what, as I was 5.5, 6 years old, and almost 7 when my mother died from breast cancer. And I remember being brought to the hospital to say goodbye to my mother when she was passing away from breast cancer. And my dad at the time had a conversation about with my mother about would I be okay. I was the youngest of 6 children that she had, and she wanted to know would I be okay. And my dad made a promise to my mother that I would be okay. And imagine fast forwarding the fact, and this was in the early 80s. So the woman who lost her journey due to breast cancer, I often say that my life is the amen to my mother's prayers. I'm on the other side of this, and while my mother never got to see cancer research, she never got to see precision medicine, she never got to see immunotherapy, she never got to see all the things that we have today as a result of some good research. She never got a chance to see that. But my mother never got a chance to see it because she's not here, because she's transitioned, she's passed away. But there's so many other women that are here, that are still living, that still never get a chance to see it. There's so many other boys who will have a similar story that I had because they don't have access or awareness to cutting edge care, clinical care, innovative care. And when I think about my life story, and unfortunately, I would love to say that impact of cancer and that impact of health disparities stopped with my mother, but it didn't. I was an undergraduate at the University of Michigan, and I get a call that my dad had been diagnosed with colorectal cancer. And I was devastated as a young adult, a teenager, and devastated that my father is now impacted. So the second time this disease, if you will, has hit my family. But we caught it not even early, but what I would learn is that my dad's living with diabetes and his colon cancer would not create the perfect scenario for the type of care he would get. And he went on to survive from colon cancer, but had complications later on that we didn't even know. So later on, when he died from complications of diabetes and colon cancer, and at this point, I'm in my career as a cancer disparities researcher, I keep asking myself, what can we do? And I had a conversation with my father about going into research. And it was my father who told me. I didn't learn about the United States Public Health Service study of syphilis of untreated syphilis in the African American male in school. I didn't learn about it in school. I heard about it in school. I learned about it at my father's kitchen table. Because I came from a household where we had convenings at the kitchen table. We had convenings after Wednesday night Bible study. We talked about history. And my father talked to me about that. So imagine several decades later when I told my dad I was going to go into research. He had hesitancy. My own father had hesitancy about me going into research. And the conversation I had to explain to my father was, I said, Dad, do you know the blood pressure medication that you take? The medication that you take for your diabetes, the medication you take to lower your cholesterol. All of these medications have gone through a clinical trial. And what concerns me, Dad, is that when those medications went through the clinical trial period to go through the approval for your doctor to be able to write that prescription, if there were not people who looked like you, who lived like you, who had similar health experiences, similar genetic makeup as you, we don't know if the medication that you're taking is truly the best medication for you. I understand, Dad, why you don't trust the system. I really do. I said, but how do we move past the justified medical mistrust? We use the word medical mistrust, but we don't often say it's justified in many cases, right? So I said, Dad, how do we move past this justified medical mistrust to get to a place where we can be a part of the solution? And his answer was very similar to Ms. Head. He said, you're the way we move past it. He said, you're the way we move past it. So I charge you to do this thing the right way. And he let me know it was not going to be easy, but to encourage me to do it the right way. So several years later, I'm now a cancer disparities researcher. I'm working and I hear about this program from my mentor, Dr. Robert Wynn, called the All of Us Research Program. And I said, I have to be a part of this. And the reason I had to be a part of it was because it was different than what I had ever heard from research studies before. I used to really get discouraged when I would try to go into communities and talk to people about the importance of diversity in clinical trials, about the importance of participating in research. And many times I would be successful in getting people excited about participating in studies because I would talk to them and they would say, well, Karriem, what happened to Henrietta Lacks? What happened to those men in the untreated syphilis, that were never treated? What happened to them? I don't want it to happen to me. And I had to acknowledge that those historical wrongs had happened. But I also had to let them know about things that are in place now that Dr. Sodeke talked about, the institutional review boards, informed consent process, and for us to have different ways of doing research before. But then I would encourage them to become a part of the study, and then they would not be able to participate because the inclusion and exclusion criteria wouldn't allow them to participate. The study wasn't even designed in a way that they could take part in it. So imagine going out and educating the community and about participating, only to find out that the study is designed where you can't even participate. So when all of us came to be, what I loved about it was that it was a study that could include everyone. It really setting out to include all of us. And unlike other research programs and research studies, it was not testing a new drug or a new device to see if this drug is better than that drug. That type of research is important. But what all of us was doing was setting out to collect information through a transformational way of us thinking about diversity, equity, and inclusion, and to ask those critical questions of who has not been included, who has not been at the table, and why. And so when I think about this concept of where we are today in the All of Us Research Program, we're 5 years into the program. And our goal is to collect information from 1 million or more people over the next 5 years so that that information can get in the hands of trusted scientists, in the hands of scientists that are going to do it the right way and ask the right questions. And I want to make sure that when they get that information, that the data that they have truly reflects the diversity of the U.S. But also I tell people that the messenger matters too, right? I want to make sure that there's researchers. That's why it's so important for us to be here in Macon County, because the history that Tuskegee University brings to the table and other historically Black colleges and universities, we can't do this work without the community, but with also being committed to training the next generation of scientists who know the history, who know the injustices, who have the lived experience to be able to help translate this message. So that's why I'm here today. And when I thought about doing this, I knew I had to call my colleague and my friend to help me spread this message, because I knew that, yes, they're difficult conversations and they're tough conversations, but this transformational way has to be built on transparency, has to be built with a commitment to doing this the right way with the right people. So I'm so thankful to all of our partners who are here today that helped make this happen. And I'm thankful to the community. I'm thankful for you all having us. And I look forward to us having a conversation about healing and trust and moving forward.
Thank you. And I have to say to you, thank you for sharing your sacred story. It is within the context tonight. If you are not aware, this is only day one of our two-day discussion. And tonight, the emphasis is on the history of research and clinical trials and the impact on the African American community. It is within the context of all of us that the program planners, Dr. Watson, Dr. Sodeke, and others, decided it is essential that you hear from the voices of the descendants of Henrietta Lacks, of Lillie Tyson, of two of the most noted unethical trials in the world. And so tonight we want each of you, returning to Mrs. Head and to Ms. Robinson, if you would share with us, why do you find yourself in this position? I know what your father told you to do, but tonight you're in this space where we're hearing from Dr. Watson, whose father told him that he had to carry on even though he was hesitant about research as it pertains to African Americans in the context of healthcare. How do you feel about being in this space tonight?
I feel encouraged. And I also feel inspired to be here tonight. Although I do still have concerns, and I guess the only way those concerns will be satisfied is by getting involved. So I'm here because of just what my father said or asked, that we make sure it doesn't happen again. We can't make sure that it doesn't happen again if we're not involved. So we need to know, we need to ask the tough questions, and we need not to be afraid to speak on behalf of how we feel and how people around us feel and how people that look like us feel. We have to be honest about that. And we should expect, or more or less demand, that we are told the painful truth about what actually happened. We see transparency. And when something goes wrong, we see accountability. As in the syphilis study, none of the medical doctors were ever held accountable. And you see that even now sometimes. Things happen within the medical community, and there are serious damages that happen, but you don't see their accountability. We need to acknowledge that and make sure that the transparency is there, the painful truth is there, and that we see accountability when things are going wrong or when something happens, even to one of us, we get some type of explanation. And then the results of what is being happened is shared.
Thank you. Ms.
So me being here, can you hear me? Let me make sure I pull it closer. So me being here, I'm very empowered. But I also know that this is such a great responsibility. I was telling you earlier that to be an advocate, to carry your own legacy, it comes with a responsibility, because you're no longer just a voice for your family and for the wrongdoing of your ancestors, but you carry a community of people who've experienced likeness of things that have happened to their families, whose voices are often silenced. So I remember growing up, my great-grandfather Day used to always say that if you're not a part of change, you're part of the problem. And at a young age, I never really knew what that meant, but now I understand. It's our responsibilities to take things that's happened to our family and things that happens in our communities, the things that are televised and we hear about way too often. It's our responsibility to empower, educate, and inform others. Because if we inform others, we can make those educated decisions that my great-grandmother, the men in the trial, were unable to make. I just want to share how I came to all of us and how this became my big brother. So we were invited to the White House at the time where everybody's president, former President Obama, was serving in office. So we were so excited. And the Lacks women were all dressed up, and we took a couple other, the Lacks men. So we went, and it was amazing because it was the first time that I heard about the Precision Medicine Initiative in all of us. As Obama spoke with all that swag, we were like, I just zoomed into every word and I was like, that's my family story. Like, I want to be part of this. But at the time, I didn't understand. I didn't know how I would be part of all of us research. Later on, a story of divine intervention, I met Dr. Wynn, Dr. Dar, and Dr. Watson, who, once I learned that the parts they played in all of us, I was just like, yeah, I want to be part of this. And Dr. Dar said, don't challenge me, because when I call you, and did she keep her word? As each one of them, Dr. Wynn and Dr. Watson, anytime I call on them, like, I can ask any question. I can say, Dr. Watson, can I get your research on patient navigation? Which has helped me recently because my mother-in-law was recently diagnosed with breast cancer. And because of sharing research and partnering, I was able to give, in those times it's so intense. So you don't really think straight. You can't make those great decisions, especially when you're not educated and informed. So I was able to be that person to inform my sister-in-law and my husband as to what this meant for us, what questions needed to be asked. And the doctors was like, ain't nobody ever asked me this. So I knew we was on the right track. But through partnership, being holding each other accountable and being deliberate in what we want to see, the change we want to see in our community, and being transparent, those were the keys to our future prosperity. And just to be around people like yourselves that hold all these keys and are unapologetically opening up doors for people like me to share my story on a larger platform. I always say that far too often our voices are silenced. I went to the next time I went to the White House, someone asked me, they said, we were in breakout sessions. They said, why is it important for you to be at this table? And it was simple for me, because we hear on repeat, right? Our zip codes shouldn't determine the care we get, but we don't always hear those things from the people that look like us, that live, eat, sleep, pray, and serve in the communities that we come from. So I looked at him and I said, because it's important for me to be here, because no longer should we be conversations on the table, but we should sit at the table to advocate for people who look like us. My family has started this movement, and it's simple. Nothing about us without us. We have to hold our friends who are in higher positions, government, people who've been through the same things we've been through. We have to hold each other accountable and be unapologetic by saying, I know you didn't just do that. Because in order to do better, you got to know better, and you have to challenge people's minds so that we can see change. We far too often are sweeping stories like Henrietta Lacks and the men in the study, like we sweep them under the rug, and we don't think that it's going to create a molehill, and eventually we'll keep tripping over the same problems. So today, that was the message God gave to me. We have to be deliberate, transparent, not just acknowledge, but hold each other up and accountable.
I really like that term, and I wrote it down. The saying, nothing about us without us, which allows me to segue to you, Dr. Sodeke, within the context you talked about the history of the Belmont study And in the context of how do we, for you as a bioethicist, how do you help us? The Black body has been bruised, murdered since we were brought here within the context of slavery. What are your words to us tonight with regards to how do we move from the unethical treatment of the Black body to us being intentionally inclusive to become active and at the table of health equity as African Americans?
I'm so glad that you asked that question, and here is how I'm going to answer it. I'm going to pivot using what Ms. Robinson said, that quote, nothing about us without us. We actually took that to heart, that sense to heart. Is Dr. Lucinia Dunn still here, or is she somewhere there? No?
She's over here.
Oh, she's over, where are you? I can't see
Oh,
you.
she said
She's not, okay, she left. All right, so that's one of our ball carriers, to use the football analogy again, within the community here, and talking about empowering us, right? This lady, along with Ms. Bernice Frazier, who you all know, the chairman of the Macon Health Commission. We thought that we needed to gather some interested, passionate people within the community to train them in ways that they can feel empowered, understanding what these regs are, so much so that they will know the right questions to ask whenever any research comes into the community. They will know about the informed consent. They will know how to weigh the risk versus the benefit. I spent, I should say, upon their own invitation, 7 sessions. Those who wish to do these a 1.5 hour session may turn to 2 hours, and then, before 7 different sessions to try to get them ready to take an ethical training, at the end of which they get a certificate. This is free. They don't have to pay anything for it. And it's one of the services that, as a bioethicist, I believe I should offer to my community to make certain that people feel empowered to do what they need to do, particularly so far as the human research is concerned. This test is hosted by the Society for Behavioral Medicine. You may know about that. So after the preparation here within the community, we call them Community Research Advisory Board, right? I chair the Institutional Review Board at Tuskegee University. So it's not hard to imagine when, in fact, the community can feel as powerful as that to take ownership of scrutinizing this research for the sort of thing that Ms. Robinson was referring to, about transparency, about accountability, about raising the right questions and insisting on getting the right answers to these questions whenever any research opportunity comes to the community.
So that's the sort of thing that we've been busy, trying to do here, even before the All of Us research program initiative came to be.
Thank you. We have to say thank you to the community researchers
Yes.
that you named. And I will admit that I'm going to speak for myself, if you allow me. There's still this sense of mistrust. Although you're seated here, Dr. Sodeke, and paraphrasing a statement that you made earlier, Ms. Robinson, in terms of being at a table with people who look like us in order so that you will feel that you can trust them, Ms. Head as well. But Dr. Watson, you also mentioned that so the way my perception as the moderator, what I heard you say is that you're an intersectionality, if you will, of the real lived experience of the mistreatment of the bodies, of the Black bodies, in terms of your parents living with cancer, transitioning with cancer and other ailments noted that African Americans die of. And here you are, yet before you were able to hold that conversation with your father about mistrust and not going into clinical research, but how can you share more with us about how is all of us different, that you can not just communicate, because we have been talking for years, but how is all of us different, and why should we follow your lead in terms of health equity?
And thank you so much for that question, but I would just rephrase it in not following my lead, but following our lead. One of the things that all of us is different, and is in a similar way that Mrs. Head said, you partnered with them. So one of the things that makes us different is this concept of participants as partners. We can't do this work alone, and nor do I want to do it alone. And there's actually evidence and data that shows when you do work with community, that work is better received, it's better sustained, and it goes further. The results go further. And so one of the things that make us different is this commitment to partnership. But I want to also go back to something that we don't talk enough about. We talk about medical mistrust, and that puts the onus on the side of the community, that the community doesn't trust the process. The community, there's still mistrust. But we don't talk about trustworthiness. We have to create systems where we're trustworthy. And so one of the things that we're committed to in all of us is for us to be trustworthy partners in this work. We don't put the onus of becoming more trusting on just the community, because the reality of it is, and excuse me if I have to give a little bit of, the flavor we bring, sometimes it saves our lives to give things a side eye. You need to give some stuff to side eye and be okay with that. Because, and I tell my colleagues all the time, well, Karriem, I want them to trust us. And I ask myself, what have you done to become trustworthy? They don't know you. They see you when you want something. You have this helicopter approach way of doing things. You fly in and you fly out. And so I wouldn't trust you either. So what have you done to become more trustworthy? What have you done to put a commitment there to show that this is more, we're committed to doing this the right way? And that's one of the things that makes all of us different, is that we're committed to doing this the right way. We understand that, yes, it's important for us to get to the 1 million participants enrolled in this study so we can really begin to understand some tough questions. But we also understand that there's been systemic and historical barriers that have prevented us from being involved in research, not just from the medical mistrust, but many clinical trials don't even happen in our community areas. Many clinical trials aren't even designed to address the disparities that kill us the most. Many clinical trials aren't even designed in a way that allow us to be included. Many clinical trials are not even designed by us. So when you talk about nothing about us without us, we also have to be the scientists designing the studies as well. And so when I think of this FUBU conversation, for us, by us, I think of it in a way that goes across the research continuum. And then I'll tell you this next story. I'm trained as a cancer disparities researcher. And I was studying, and again, like I said, imagine the blessing I got to live every day with my mother dying from breast cancer, but me being able to live out her legacy through helping to find cures and doing research. So I was looking at disparities in lung cancer. We talk a lot about breast cancer and prostate cancer, breast cancer in women and prostate cancer in men, but we were not talking about the fact that lung cancer was the #1 cancer cause of death amongst African Americans. So when I went to design research projects to educate African Americans about getting screened for cancer, for lung cancer, I looked at the previous studies that have been conducted, and although we carry the greatest burden of death due to lung cancer, when I looked at a study, we were only about 4% of the participants. So then imagine when I had to go back to my community clinic and implement the results from that study in this community clinic. So I had to tell primary care providers in a federally qualified health center, a community clinic, that in order to screen someone for lung cancer, they have to be 55 or older. They have to have smoked for 30 years. Then I went through all the guidelines. And one of the doctors looked at me like I was crazy. She said, Karriem, who came up with these guidelines? Our patients don't smoke like this. They don't, like, where are the real issues that we're dealing with? Where's the exposure to environmental toxins? Where's the questionnaire about what does stress and racism do to the body? How racism gets under the skin, right? She's like, where are the real issues that's leading to cancer disparities? And where's that in the questionnaire? But none of those questions were in the questionnaire because we weren't designing the research study. So we set out, a group of us that was led by Dr. Wynn and others, a group of us set out to rethink the narrative. And many of them told me, well, Karriem, it's going to be difficult for you to engage Black men in research because they called us a hard-to-reach population. They said, Black men are hard to reach. I said, well, I'm a Black man and I'm not hard to reach. You're not going where we are. Or when you come, we don't trust you because you've never been here before. So if you want to reach us, become engaged with us, not just when you want us to join the study. Don't just get engaged with us when you want us to join the study, and don't just be engaged with us while the study is going on. You have to make a deep investment and a commitment to this work. And that's part of the partnership that we're trying to build with Tuskegee University and in other communities as well, is to build that trusted partnership. We're here today in large part through support that I have from my partners at Pyxis Partner and others. And we have tons of community partners. One of the things that all of us did differently too, before we enrolled our first participant, we created an ecosystem, a network of community partners. We have over 150 community-based organizations that are holding us accountable and telling us how to do this work. We think about populations living with disabilities who have been historically underrepresented in research because of access. We have the American Association of Health and Disability helping us to think about doing this work. We think about the impact. We're in Tuskegee, Alabama, and we think about historically Black college university. We think about the impact of Black sororities and Black fraternities. We have the Delta Research Educational Foundation helping to hold us accountable and saying that we have a reach much further than you. And if you collaborate with us, we can help you get that message across. So one of the things that we're doing differently is creating a community engagement ecosystem to help us engage community members in a way that we treat them as partners.
Thank you. So I was getting ready to ask you, I think that it is appropriate within the context of your title of your foundation is Uplifting the Voice of the Fathers. And so what do you think about this system, this new system? He's deconstructing, all of us, deconstructs the system that mistreated your father and the men that were in the study. What do you expect to happen from all of us within the context of partnering and community?
I truly hope that that partnership will continue and be expanded even to include more people from the community to be a part of that discussion. That's very important. The Voices for Our Fathers Legacy Foundation awards scholarships annually. And since 2014, we have awarded $27,000 in scholarships. That's pretty good, I think, for a small foundation. And one of the things that we try to encourage and we promote is that people like us, look like us, consider going into a field such as research, medical care, health care, hospital administration, and so forth. So I think that is something that I would like to see on the table as you're going around encouraging young Black people to get into the research field, because that will truly make a difference. And we need to do that. And provide opportunities for those young people perhaps to have an internship with all of us, to learn and to do, because that will help to spread. I think it's really important, similar to what Ms. Robinson said about being at the table. I have heard, and I share another quote: if you're not at the table, you're on the menu. So we don't want to be on the menu any longer, and we don't want to be away from the table. So the community, to me, is so important, and especially when you go out and talk. And don't just talk to the ones who understand you, talk to the ones who don't understand you. And Dr. Sodeke has talked about the consent form, which came, and, well, the consent form, believe it or not, was there before the men, but it was not used for the men. They just disregarded that altogether. But in the consent form, and we've all signed consent forms, but how many of us really take the time to look at those consent forms and read them and understand them? So that's another thing that I would encourage as you're talking and going out to the different communities, to really understand, and don't be afraid to ask the question, because no question is dumb.
Dr. Burrell, if I may, I know we're getting ready to open up the floor to questions, but another question you just sparked, you asked another thing that's different, and one of the things that really sparks me is this concept of value. We use that word a lot, return of value, but one of the things that all of us is committed to is returning value and even returning results. We just recently collected information, and we're returning that information back to participants. So that is so key and so important. Because when you return information back, we're not just giving information back, because when we collect information, we may learn about the fact that some of our participants, as a result of information we collect, we may learn that you may have a family history of colorectal cancer through a condition called Lynch syndrome. And when that information gets returned back to you from our study, you will then also get an opportunity to meet with a genetic counselor. And that genetic counselor will walk you through what to do with that information that you just got back. Because we can't afford, we owe it to our community, not just to collect data, to publish papers, and to move the needle, but we owe it to our community to be able to collect that information and give it back to them, and then say, now these are ways that you can be empowered to use this information. And so the fact that we have partnered with genetic counselors to return this information is so important, and that's another one of the ways that we're doing things differently as well. When we publish things about that, you can go on our website and find out. I'm a participant in our program too, right? And so I really want to know that it's safe and that we're doing things the right way. And I'm proud when I can see a study that was published recently, that talked about looking at all of us data to better understand how African-American women and who have hypertension have elevated rates of preterm and early birth. That's what we're seeing in the country around these elevated rates of maternal and child health. Black women having, and we know a lot of this is due to things like racism, lack of access to care. And to be able to go into a database and study that and then return that information back is also something that we're doing differently.
Thank you. So with that said, we can't continue to do things differently without the community.
That's right.
So we need to hear from you. And at this point, please let us hear from you, because as it has been stated continuously, all of us, the research program is here tonight to begin anew. We need to hear from you about what is the next step. This is no longer about talking. This is about action, deliverables. So what do you want to see happen from this moment forward here in Tuskegee? Okay. Microphone. And please share your name and the community organization that you're representing.
My name is Dr. Lucinia Williams Dunn, and I am President and CEO of the Tuskegee Macon County Community Foundation. And I have heard a lot of things from a lot of different people, a lot of different groups, and I have to say Dr. Sodeke is probably one of the reasons that I have heard all of these things, so I thank you for exposing me to so many different groups of people who are talking about research. And I heard a lot of good things today. But my question is this. We know that we came to this country in a way that was not, quote unquote, normal. We talk about racism as though it's an objective process, which it was not. My question is, are you beginning to do research on why we have certain determinants of health as it relates to slavery? Because you see, we don't talk about slavery. We talk about slavery in the abstract form. We don't talk about slavery as it relates to policies in the United States, as it relates to racism and policies. And so I want to know, are you getting down to the real nitty-gritty, as they say, to say we are different than anybody else in the United States? Because we have a whole collage of differences. I mean, for an example, I have Irish blood and Scottish blood as well as African blood, and I don't know how many different tribes of the African blood that runs through my body. So how is that related to our health care? And are you all beginning to really help us understand why things happen to us in the way that it does?
Thank you so much for that question, and I'm going to answer it, and I'm going to answer it in a broad sense beyond just the All of Us Research Program, because the All of Us Research Program is one research study, but I'm actually going to answer your question about some work that I've actually done in the Chicagoland area, looking at lung cancer. And yes, we are looking at those social determinants of health, because where I'm from in Chicago, your zip code, your ZNA, can be more important than your DNA. Where you live can be more determinant of your health outcome than what you were born with, unfortunately. And so when we looked at these lung cancer disparities that existed among African-American men, we weren't willing to just say, let me look at, there's this thing called protein methylation, for example, right? And this can determine how severe a lung cancer is. But we wanted to go deeper and say, but what role does racism have on that? What role does lack of access to healthy foods have on that? What role does stress, just from being Black in America, have on that? And so there's a thing, like you said very clearly, social determinants of health. And yes, we have to have so many more research studies that ask questions about the social determinants of health. Dr. Rail said a term earlier about intersectionality. Intersectionality is so important because we can't just look at one thing. It's not, I'm so happy that all of us is collecting the biological information and looking at our genes to understand them better. But we have to also understand how those genes interact with the food we eat, or are informed by the food we eat and the stress that we're under. So yes, in the All of Us Research Program, we are collecting information on social determinants of health, so that researchers will be able to better understand that information. But more work needs to be done. I'm not gonna say that we're there yet. We need to encourage more team scientist approach, for example. We need more bioethicists. I get excited when I run into a young person and they say, I don't know what I wanna do when I grow up. So I change the narrative. I say, how about saying, what problem do you wanna solve when you grow up? Because that may help determine what you wanna do, right? And thinking about careers in bioethicists, thinking about careers in epidemiology, big data. These are things that we need more research done on, so that this question of, are there studies happening that's looking at the true issues of racism and social determinants of health? Yes, there's some, and yes, in all of us, we're asking about social determinants of health, but we need to do more.
Yes, Dr. Sodeke.
Thank you very much, Dr. Dunn, for that question. It's a timely question in the sense that you will be on the same session with Dr. Clayton Yates tomorrow, who is involved in these kinds of issues now. Now, just as a matter of PR, if you will, and to invite all of you back tomorrow to come back and listen to this effort to try to figure out
how researchers and communities can actually collaborate. So if you're raising that question tonight, keep it burning till tomorrow during your session. You might even raise it again. But our own Dr. Yates has been to Nigeria. His specialty is prostate cancer, and they are beginning to discover certain things. Okay, he might wish to share that with the audience tomorrow, but he's been to Nigeria, he's been to Ghana, he's been to Central Africa. The man is just so energetic and all over the place, trying to figure out these sort of questions that are very pertinent to this opportunity to collaborate, to really look at, feel the pulse of what is it that is so concerning to our communities, and then have the community and the researchers put their heads together and figure out how this is possible and what to do, what steps to take. I meant it when I said, when I was giving the statement of purpose for tonight's law. We're through talking, we can still talk, but now we need to figure out how we move forward. And that's a pointed question that you raised. There might be other likely questions here, but it's going to take all of us, no pun intended, to figure these things out. And the session number 3 tomorrow is especially designed to address questions like this. Thank you.
Thank you. Hello. Another question?
Right here. Right here.
There's someone at the.
That's right.
Yes.
They can't see you from the light.
Oh, I'm sorry.
There
Yes.
we go.
Okay.
Yeah, right. Ms.
Okay,
Page.
good evening to all of you. I am so excited to have you here and appreciate you sharing with us. And Mrs. Head, I was here working with you before when you did the Voices of Our Fathers luncheon here. My name is Bernice Frazier, and I'm the chairman of the Macon County Healthcare Authority. My question to you is going back to the basics. I know that you're giving the overview on everything that you're going to do, but if now I have become interested in being a member of the research, what does that look like? If we're going to go back to saying, I signed this consent form, and what does that give you the right to do? What are the steps? Are you walking with me? I know that you shared with us what happens if you have something and the genetic counselor will come back with you, but what is the process and the breakdown of the basics of how an individual becomes a part of all of us?
Thank you so much. That's a great question. And I have colleagues in the room, too, that are helping with the All of Us program, too, and can help us answer this question. But the first part starts with the conversation. So thank you so much for that question about the consent process. And I actually like to say, I don't like to just say the consent form. I actually like to say the consent process, because it's not just the form is one version, is one part of that process. And being a participant in the All of Us research program means that you agree to share several different types of information with us. One of the types of information that participants will agree to share is biological. And what I mean by biological, that means that we will take either a blood, a saliva, spit, or a urine sample. And from that's where we get information to learn about the genes and everyone and how the genes may interact with everything that's going on. That's one set of information. Another set of information we collect is of surveys. So that question that was asked so wonderfully early about social determinants of health, we would ask you to complete some surveys about social determinants of health, even about your experience with COVID-19 and other surveys. And typically, you don't always see that type of information collected in the same place. Another thing we have is access to electronic health medical records, because by understanding what's in the health medical record, we can look a period over time. Another thing I didn't share is that my family has a history of, I'm so happy to see the gift of hope back there, because my brother, who recently died of colon cancer complications, was also a kidney transplant recipient. And so as someone who's the brother of someone who died of colon cancer, but also impacted by chronic kidney disease. I want to better understand what my labs mean over a period of time. So I'm excited about the fact that a researcher will be able to look at my genetic information, but then also be able to look at my lab value through my electronic health records and see, have my labs changed over a period of time? And people who look like me or who have similar makeup that I have, if their labs, these renal labs change, what does that mean? How can that inform how we think about chronic kidney disease? How can that inform the medication that you may need to take? How can that inform the conversation I have about preventing diabetes? My doctors and I have a conversation and say about that, and I know that because of the information I get. So imagine having all that information in one place for researchers to be able to better ask questions from. So that's one thing a participant can expect as well, is to donate that information, to provide that information to us, and for that information to be used for research. And then you may be contacted again to ask, have you updated your information? But at any point, if you decide that you no longer want to be a part of the program, you also have the ability to say, I don't want to participate in this program any longer. And that's what we call, you have the ability to withdraw from the program. But what participants can expect is that there will be a partners to go alongside you in this journey, to talk to you about what it means to be involved, to talk to you about how your data is protected and even de-identified as well, meaning that people won't know your name and who's participating, which didn't happen with the HeLa cells. They used Mrs. Lacks' initials, which is unethical.
Thank you. If no one, I cannot see because of the light. Is there a person? Great. It looks like Miss Wilson.
Yeah,
Yes.
it is, and my name is Cynthia Wilson. I am a retired employee from Tuskegee University from the Bioethics Center, and I'm a return to the employment in the Legacy Museum currently. But I'm here as a community member, and because you've hit two areas that Dr. Sodeke knows are my problems. Informed consent. Informed consent is only as good as the person understands the informed consent. And the problem with informed consent under research projects, because I've been a member of a clinical trial, I have a college degree. I worked for 3 institutions of higher learning. I read that thing and I didn't understand one line of it. Okay, it took my uncle, who was a microbiologist, a registered nurse, a cardiologist, that man sitting over there, and my boss to go through that thing with me for me to understand it. Okay? So when you hand somebody in a doctor's office, most of us, like Ms. Head said, we'll sign the informed consent, hadn't read a line, have no idea what we have consented to, and then are confused when all of a sudden our records end up somewhere, or we end up with something we were not expecting because we didn't read that informed consent. The informed consent for research projects are written for the IRB, which means it's not necessarily written for me. Okay, and then the second becomes a patient asking questions. People are scared. I have the utmost respect for the Lacks family and for the family members of the study, because they end up being the default explanation of most people for what they don't understand. It's not that it has anything to do directly with whatever happened in the study. It's not that it may have anything to do directly with what happened with Ms. Lacks or them understanding any part of it. But they know they don't trust it. And the way of describing that distrust is, in shorthand, what about the men in Tuskegee? What about Henrietta Lacks? That's the thing I'm looking at. How you gonna answer? Because it's nice to say the informed consent is there for us to do, but how are you gonna empower people to actually ask the questions they need to ask? Now, everybody in this room that knows me, know that ain't a problem here. Okay, I'm gonna ask you a question and I'm gonna ask you until you answer me. But my mama was a nurse and she taught me to do that. everybody doesn't know how to ask a question. So while we're talking about the informed consent and understanding the research, and just like the baby said, they handed them a book with a whole lot of medical terminology in there that they didn't understand. How do we get our community, how do we empower them? How do we train them to say, hold up, what you about to do? And explain it to me so I can understand it. That's the issue for me. Because if we don't get past that and past them understanding what's going to happen with that research, how they're going to be able to access that research, what you doing with that stuff. You know us. I'll smile at you, tell you hi, put that piece of paper in my pocket, and you ain't going to see me again. So how do we do that so that we empower our community to exert what informed consent actually gives them the right to do?
Wow. That was, is it on? Yes. Okay, well, that was very empowering within itself.
Yes.
And the community need people like you. We need people like you in our families, because that's how we become empowered to ask the questions. In my family, there's a younger Lex who, just by accident on purpose, that an older Lex has pushed into the medical field. And as I said, my great-grandfather said I was mouthy for a reason. So now I have 4 different family members who I'm responsible to go to doctor's appointments with. And a lot of times, our family's cultural stories, it keeps us silent from asking these questions, like that saying, what happens in my house, stay in my house, which means that a lot of your medical history go unknown, which means that because of that mistrust that you have in the community, Thomas Salks and the smallpox vaccine, and our body's been exhumed from the grave, the Henrietta Lacks, the Tuskegee study, all these things that have happened and history continuously repeating itself has silenced us and made us feel very uncomfortable with the people who we should be more trusting in our care. So I encourage everybody to tell your family members, tell your friends that we are no longer just patients, but we're partners, because we get one life and one body, and we have to protect ourselves. And we can't just say that, hey, we are holding you accountable for my life. Because if something go wrong, everybody looking for that fall guy. But in my family, like I said, we all go, and I ask the questions that my grandfather's afraid to ask. And because he has that concept of what happens in my house stays in my house, I have to ask, like, where did this come from? And a lot of that is, well, when I was growing up, they said that John Hopkins, they would do research on you and they would snatch your body up if you was out past this certain time. Everybody have these cultural stories and things that they can relate to, but it's our responsibility to be sure that if you know someone is going to, like my mother, she won't tell a doctor nothing. She will go in there and she'll say it's all good. And then she'll get mad with me when I pop up at the doctor's appointment. What you doing here? I'm like, you have to make sure that you hope that you protect your family by also being a voice when they feel like they have no voice.
And I also want to thank you so much for that, and add to that. One of the things that we've done, and you're absolutely right. The consent process is something that has to be continually addressed. And and to your point, there's even that you have supposed to write the consent form at the 3rd or 4th or 6th grade literacy, usually 3rd or 4th grade literacy level, right? But still, when you read it, you are absolutely right. It's still not at that. So we've done some things where we also use videos. We actually, at the end of the video process, after you watch the video and read the consent, if you read it online and you go through it, you have to answer a series of questions. But to your point, you're absolutely right. Sometimes people answer those questions and still don't know. That's why we have to be in this types of partnership. That's why one of the things that we have is a patient advisory board. But beyond just your typical patient advisory board, we have them participant ambassadors, participant partners that are reviewing our documents. And we have people that are saying, no, Karriem, this is not going to cut it. We need to go back to the drawing board. We need to go back to the table because this is not going to get it. But we need more of those conversations. And we need more bioethicists. We need more Dr. Sodeke's, because we need people actually writing the process for what it means to go through the informed consent process. We need more of that. And I would love to share with them, Dr. Sodeke, how we do it in all of us and walk through that process maybe tomorrow even, so we can really begin to address this concept of the informed consent journey.
Yes, did you want to? Yes, so it is my understanding, as I'm being guided in this process as the moderator, so it is 7:59, and at this point, if there are no more questions from the community, the rest of the community, we're all community, we'd like for Ms. Head, Lillie Head, to share with us your thoughts at this point.
My thoughts is on a question that I have. As you know, we do not have data for the research that was done on the men. We don't have that. You will have the data for the research that is being done with All on Us. I have understood and read that once you take the specimens or samples, it becomes intellectual property. And by it becoming intellectual property, it can be shared with anyone. Who will the results, the data from all of the information that is being gathered from here, who will have access to that, and how would that be shared, if so?
It's a great question. So for all of us, and it differs across different research studies, Ms. Head, for all of us, the way the data will be shared is that it's information that people, if you go through a series of trainings that bioethicists and others have gone through, you have to actually go through a series of trainings before you can get access to that data. And we don't share, the biological samples right now are not being shared. What's being shared is the information from those samples and how you process that. So it's not that someone right now, there may be a day when we have these larger ancillary studies where someone can go through an ethical process and request that information. But right now what's shared is just the data, not the samples. And I'm sorry, go ahead.
Oh, I'm sorry.
No, you.
And sometimes that data can be used against you.
Yes.
And that's my concern.
It's my concern too, Ms. Head, and we have a researcher advisory board that before something is, if in order to utilize our data, you have to go through an approval process. You have to say that I've completed this training, and you have to tell us what question are you going to ask. And if we determine that that question that you said that you're going to ask is what we call polarizing, they're going to stigmatize the community, we actually will not approve that question from being asked, because we have to make sure that we can't do more harm in this. And once that research is approved for that question, then that research is conducted and that person publishes the paper. And if we still have an opportunity then to be able to say, no, this doesn't align with ethical principles, because we cannot do harm and use that data for further trauma.
Thank you. Dr. Sodeke, you're going to have the last word.
Okay. Very well. It has been a very edifying, riveting evening and evening of conversation. Has it not been? Yes. I want to pivot to the last question and the answer that was given, to just let you know that I co-chair the Resource Access Board within the All of Us research program that Dr. Karriem Watson, my brother and friend, was just talking about. This is how we make sure
that this data is not being used for nefarious reasons. We say, what do you want to do? How do you want to do it? What do you aim to get out of it? How are you going to interpret it? If any of all those questions are not answered correctly, that particular person is not allowed to go forward, nor will the person even have access to the data. See, there are 3 layers of check and different levels of data, right? From the one that is public facing, okay, summary of everything, right? And then there is the registered tier, which goes through all of these questions. And then there is the controlled tier, which means there are more details there that we want to protect from just anybody, trying to get in there to do whatever, right? So I can assure you that the privacy is very important, confidentiality is very important. The scientific rigor and merits of all of those researchers are so important to us that this is why this All of Us research program is different from any other that we have going on anywhere else. I want to express my sincere thanks to all of you who stayed the course. Thank you so much, Bob, for being here. I want to invite you to be here again tomorrow because the conversation never finishes, it continues, you see. And come and hear some more and contribute some more tomorrow. God bless you. Have a good evening.